So let's turn now. We're a bit behind time, so we'll just keep barreling straight into the next industry area. And I don't think there's any doubts whatsoever that that if we're in a war here, in a battle, then the front line is the health and healthcare industry. And I'm sure that many of you will be like me, where you basically every day get up and shake your head in wonder at how they continue to do the amazing job that they do. So we're very grateful and we're very privileged to have two great speakers here today to talk about the healthcare sector and what it's facing and where we're going. There are two speakers. I'm going to introduce the first one is Mr. Peter Williams, and then I'll be introducing Joe Stevens a bit later on. But Peter Williams is a fellow and director of the Australasian Institute of Digital Health. He's Oracle's healthcare advisor for the APAC region, Asia Pacific, helping healthcare organisations use technology and data to gain insights that can drive business transformation and digital evolution. Prior to being at Oracle, Peter's career in government included senior roles within the ABS, the Bureau of Statistics, that is, Defence, Social Security, the National E-Health Transition Authority, Victorian Department of Health and Human Services, and New South Wales Health. He's also led the statewide implementation of business and clinical information systems. So with that, I'm pleased to introduce Peter Williams.
Hi, Daryl. Thanks. So, Chris, are you loading my slides?
James, I've got them. Yep.
James, okay.
I think they're there.
Yeah, I'm not seeing them at the moment.
It's saying challenges for healthcare analytics. Is that the one?
Yep. For some reason, it's not coming up on my screen.
Oh, we may need Will to fix that.
But that's okay. If I know it's on the slide, so if you just go to the second slide, thanks.
No worries.
Okay, so just to give this some context, the health system is a system that even before the current pandemic was a system under pressure due to aging care, chronic disease, just general cost pressures that being experienced, not just in Australia, but right across the world. And health is trying to achieve really four things. They often talk about the quadruple aim, and that is that we're going to have a better patient experience and outcome, we're going to have more effective and more satisfied clinicians, we're going to have better population health, and we'll have lower unit cost. And you add to that, certainly in a public context, greater equity and access for vulnerable populations. All of those things require a lot of data to understand and deliver on the expectations. And that's getting more complex at the moment because you have a whole range of new data sources, because as the health paradigm shifts from a focus on treating sickness to treating wellness and the whole longer term support of people in the community, there are a whole bunch of things outside the healthcare system that have an influence on that, where people are living, what are their economic circumstances, and a lot of new data sources. For example, the Internet of Things, mobile phones, Fitbits, it's estimated information from those non-traditional sources will double the data that's available to healthcare over the next 2 years. And that creates challenges. If I could have the next slide, please. At the moment in healthcare, typically data is held in separate data silos. If you look at the clinical system side of this, even in hospitals that may have implemented an electronic medical record, there's still information being held somewhere in a spreadsheet. There are lots of specialised systems. When you move across to the other side and look at more of the sort of back office and corporate type functionality, then you have the same sort of problem. You have perhaps a different vendor providing a finance system, from your HR system, from how you manage your supply chain, and so on. So you have this mix of multiple technologies. And what that does, it makes it very difficult to assimilate all that information together and to be responsive in the sort of timeframes that are needed. And probably a good example of that in the current climate is the challenge that governments around the world have had in how they manage the supply and distribution of personal protective equipment. You know, who actually has information? How are we going to forecast the need for that? What's the impact of even things like seasonality, climate? You know, it's different in winter than it is in summer. It's a very complex world. If I could have the next slide, thanks. So if you look at information management best practice, and there are some good examples of this, if people are interested in this, particularly in healthcare, it's worth having just going on net and looking up Gartner and Baycare. Baycare are a US organization who won Gartner's Global Information Management and Governance Award a couple of years ago, and they've got some really good materials about how they went about this. But it's hardly surprising, and particularly not to this group, that the key is to focus on the data and not the technology. And in doing that, to use open standards as much as possible, so that you avoid the challenges of trying to integrate and map data and maintain that sort of complexity as all those systems move around you. And there are different ways you can do that. If I look at my own organization, Oracle, their financial system, their HR systems, and their CX systems all use a common data platform. So in fact, you don't have to worry about that integration element with that. And that sort of platform approach is really making a large difference right across industry. Again, if we look at the current crisis, there is a site in the US called MiPasa, which was developed by Wharton University in response to the COVID initiatives. And it's a platform for sharing a whole bunch of research information, including, for example, the Johns Hopkins data and stuff from various governments. And that platform was built in a collaboration between Microsoft, IBM, and Oracle. Now, that sort of interoperability would not have been possible going back a decade or so ago. Another good example of the advantage of having this focus on open standards and common data is that you can deal much more effectively with real world problems. We've just had a discussion around the growth of the use of telehealth. What's of interest to government in that will be, well, has that been effective? And to understand that, then you need to be able to pull together data around cost. You need to pull together data around effectiveness. You need to understand what its impact was on workflow. So again, taking a data-centric rather than a technology-centric approach is critical. And you might think that was self-evident, but interestingly enough, ISO has just formed a task force looking at information and data governance. And one of the things that they have noted is that while there's lots of, if you like, best practice information around this, by and large, and this is focused on healthcare, it hasn't been applied. Which, if I could have the next slide, thanks. And they also, at the moment, have a task force on artificial intelligence. And artificial intelligence is, clearly something that's critical. It gives us new insights. It will accelerate understanding, but it's got a challenge, and that challenge is around how much is the result trusted by the community or by the people who are using it. And within that, there's probably a couple of things that are critical. The first is there bias in it? And to give a practical example of that, the FDA in the US approved an algorithm for use with diabetic retinopathy. And that's a large issue with the Indigenous population in Australia, and a group in Western Australia were looking at applying that algorithm. But they quickly realised that the algorithm was developed based on 1 million middle-class Americans. Maybe the data and results would be very different if we applied that to the local Indigenous community. And so, in fact, they've had to undertake similar analysis to see if those results can be replicated. The other key thing is around transparency. Artificial intelligence, says, I've looked at this, here's the result. What happened in between? If you're using machine learning, that can be a fairly straightforward sort of thing. You can understand and look at the algorithm. When you get to more complex things like neural networks, it's much more difficult. The comment was made a minute ago around understanding and education of these things. That's also a critical area for development. So I could have the last slide, thanks. So I guess the point I really want to make is people very much focus on what they see in front of them. Doing the analytics and doing a nice presentation, you feel you've achieved something, but that's the easy part. The hard part is on actually assembling that data in the first place, cleansing it, making sure it's as complete and accurate as possible, and then really understanding exactly what it's telling you. Thank you.
Thanks, Peter. Look, I fully agree with that. I often say that when talking to clients, people get excited by the dashboards and so on, but it's the 80% of the work is actually getting the data organised to be able to get those insights, etc. Thank you. We're going to move straight into the next speaker. This is Jo Stevens. She's the Executive Director for Community Health at Colac Area Health. Jo's been working in various health leadership roles for over 25 years. Her breadth of experience includes roles in aged care, rehabilitation, and over the past 10 years in community health. Look, her bio says during this time, Jo has been involved in the actualisation of significant organisational imperatives and service implementations. I'm going to translate that for you. Jo gets stuff done. And I think in doing that, aims to better support patients most at risk in our communities to better manage their health and well-being. And I'm sure you'll agree, if ever there was a time to hear from someone with that experience in those areas, it is right here and right now. So I'm pleased to be able to introduce Jo Stevens.
Thank you. And I'll head this up with, I have to leave at 11 o'clock because we're in the midst of COVID issues here at Colac, as you're probably all aware, and we've just had another escalation in the last couple of days, so I will need to leave on time, so I'm sorry if I miss any questions. So I've been asked today to talk to you about a project that I became involved in 2014. We had some money when I was working at Barwon Health from the DHS, and it was co-funded by Barwon Health as well. So it was a pilot model to test if the use of technology could support patients with chronic disease in self-management and developing their health literacy skills. So what we did, we undertook a pilot project for around about 2 years, but each patient was provided with an opportunity to be on the monitoring program for 12 months. So this type of program is traditionally in the industry called remote patient monitoring. So essentially patients are given equipment in their home. So things like an Android type tablet, pulse oximeter, which measures the oxygen in their blood, blood pressure cuff, and weight scales if they've got heart failure. So things that can measure whether or not the patient is actually well and how they are travelling clinically. Also, this system, or the systems, ideally allow the patients to answer health questionnaires. These are very important because they actually identify for the patient various clinical indicators that might be telling them that they're not well at the moment. And it might be as simple as, I didn't sleep as well last night, or I needed to sleep on an extra pillow, or I'm more short of breath when I get to the letterbox. So just very slight indicators within their own health and activity on a daily basis. So we ask the patient to put in their biometric data, so their blood pressure, their weight, their pulse oximetry readings on a daily basis, and answer these health questionnaires, and that information's then sent through to the clinical station. And at the clinical station, you know, Peter talked about interpreting data, and even though the system highlights what is out of range for the patient, the interpretation of the data becomes very important because you really need that clinical overlens of the patient's condition. And you also need the patient to be able to contextualise what that means for them and what might be happening in their environment that talks to their clinical stability. So that interpretation of data, certainly I have no doubt that modelling around data is going to enhance the capacity for us to do that from a systematic perspective. But we're not by any means in that space at the moment. It still requires that clinical synthesis and the interaction with the patient at the other end. So essentially this information comes through to the dashboard where the nurse is able to then interpret it. If it's out of range for the patient, for example, if I have airways disease, I might have my pulse oximetry setting low rate at 89%. If I don't have airways disease, that rating would be at 94%. So you can modify the parameters for the patient. So if I fall below my parameters, there's an alert that comes up in the system, and that then allows for a large number of patients to put their information in, and only those things that are out of range for that patient group will come to the clinician's eye. And at that point in time, the clinician is then able to do a number of things. So firstly, they may screen the information for how important it is based on their knowledge of the patient, and keep it for a rainy day. They might be working with a GP around altering medications. They might save it for a time when they catch up with the patient and they use that information to progress a clinical conversation. They may refer the patient to another health service or indeed their GP to escalate their care, or they may refer that information to the consultant who's on call. We mainly work with GPs, but at times, particularly in the current model at Barwon Health, they are working with cardiologists around a heart failure group. So if we go to the next slide, thanks. So here you can just see what the clinician might see at the station. So there's red alerts on the very left-hand side of the screen where the clinician can go, oh, I need to talk to test patient today. And red alerts we aim to have managed within half an hour because they could actually be quite critical for the patient's wellbeing. If we go to the next page. So at the end of the pilot project, so each patient having 12 months with us, we identified that we were able to reduce the length of stay by 3.9 days, and that was statistically significant. We were able to improve health literacy outcomes statistically significantly, quality of life again, anxiety and depression scores were all reduced. There was a suggested reduction in hospital presentations and emergency presentations. Mind you, I think it was about, I can't remember, about a 12% reduction, and any hospital would be happy to see that amongst their chronic disease cohort. The economic evaluation at the time saw a break-even model. And I need to preface that with the model we ran was quite an expensive one. It was 7 days a week. There was an on-call nurse if the patient felt that they needed to call them in the evenings. And we also, technology was quite a bit more expensive back in 2014. For example, data cost us around about $500 annually, and now those costs are quite significantly reduced with, with deals that we have with Optus and Telstra in this space to around about $180 a year. So significantly, those costs are coming down. Now, if we go to the next slide, I guess I wanted to talk a little bit about the actual patient experience. So the data is really important to them. It did things like it provided oversight it meant that they knew that the clinician was going to follow up with them. It drove their routine and adherence to their self-care patterns, which really we believe was part of the significant outcomes. It made them aware of their condition if things weren't going well. It validated their experience, and so when they would go to their GP with conversations about how they weren't feeling well, they were able to use their data. They were empowered to make choices about their health, and they certainly used data as a communication tool with their GP and other people involved in the care. The technology, it actually astounded me, and it quite early in the piece, that this technology that sat in the corner of a patient's room, where they basically were sending us information as a one-way communication tool, and we were then communicating back by phone or video conferencing. The patients actually found that that was a connectedness to that staff member. They felt that these people cared about them and that there was always somebody there looking after them. In fact, one of the patients identified that it was like having a wife without the commitment. And that experience was resonated with all of the 13 patients that we had done some semi-structured interviews with. So the other empowering component of this type of system is the capacity to deliver education. And the education is delivered at a point in time when the patient is actually in that process of clinical escalation. So they're not feeling quite as well as they might normally, but they're not bad enough usually to be going to seek help. So they typically wouldn't be going to see their GP right now, or typically wouldn't be presenting to the emergency department, but they're heading in that direction. So we're able to support them to understand those early signs and symptoms of clinical deterioration and personalise it to the individual, because in health, if you have one chronic disease, it's highly likely you will have another one. So comorbidities is a significant component of this sort of chronic disease picture. Did I have another slide? I don't know that I did.
No, that was the last one.
That might have been it, yeah. So overall, you know, very positive experience from a patient perspective. Clinical teams love it. We can manage large numbers of patients, and certainly Barwon Health have seen that this is the way of the future in managing chronic disease. It has all-round great benefits, you know, patients, staff, financial cost benefits, and certainly something that we can see more of in the future. Predictive analytics around slight variations in patient-submitted data, you know, is something I would love to see integrated into this type of service. I guess, you know, Peter also alluded to how services and systems in health don't support us. The team at Barwon Health are double entering data. So they enter the data from a clinical perspective, then they put it into another system so that they can count it for funding purposes. So that's just a good example of how systems don't necessarily support the health service delivery and the outcomes that we're looking for. So I hope that's given you some context in regards to a health experience.
Thanks so much, Jo. And to Peter, fantastic to hear from you guys at the front line. We might, Tyler, limit it to just a couple of questions so that we can claw back some time, if that's okay.
Yeah, sure.
Yeah. Thanks, Daryl. Thanks, Jo and Peter. So you do have a couple of questions here. This one just came through as you're speaking, Jo. Is this program still running in your organisation? Remote monitoring of patients?
Yes, so Barwon Health have been, so I'm no longer with Barwon Health. I left 3 weeks ago, but after being there for 27 years. So yes, it is still running. We were part of a pilot funding model through the DHHS called HealthLinks, and that's how Barwon Health are currently funding their remote patient monitoring program. It has a focus of heart failure, and we engage with, we have a nurse practitioner on the team and cardiologists that we liaise strongly with around the patient group, and it seems to be more than paying for itself at the moment. Yeah.
Thanks for the question. Now this question goes to both Joe and Peter. What is the strategy for standardising terminology?
Yeah.
Peter, I might let you answer that one.
Yeah, look, there are certainly, there's stuff focused from the National Digital Health Strategy, which is really looking at, at a clinical level. It's, in one sense, it's probably easier because there is a global group. There's a system called SNOMED, which looks to basically classify all clinical terms and can map up to higher order classifications for use in pathology or diagnosis, etc. It's harder on the sort of back office financial side, getting agreement on things like common chart of accounts. Again, though, that is where the sort of platform model can assist. Though Joe was just talking about the challenge in Barwon. Barwon are actually currently implementing, and their back office, they've just implemented our financial system in the cloud, which allows that sort of platform interoperability. So yeah, places are starting to look at that. The other thing is these days in healthcare, there's a thing called FHIR, Fast Health Interoperability Resource, which is designed to operate in an interoperable world. So you can actually go to a website, pull that down, use that in their system, and know that you're going to have an interoperable standard.
Thanks, Peter. Question that's come through, I think this one's directed at Joe, who's asked, this appears to still be largely symptom management and hospital avoidance strategy. How will this program evolve to be more focused on a wellness model?
So I guess when you're talking about patients with chronic disease, the horse has already bolted. Early intervention and prevention is obviously key, and I think we have more of a focus of that in health, and certainly in the portfolio I've moved into around partnerships in preventing these types of chronic diseases happening. But once you're in that space, you really need to robustly manage them so you can keep people well. And I think this type of program certainly demonstrates that you can do that to a degree.
Great, thanks for the question. Another one that has come through for Joe, that's just asked, how do you coordinate and manage communication between members of the multidisciplinary team in chronic disease?
Yeah, and so integrated care is very difficult, and that's where we need our IT platforms and our data to support that. And essentially, again, we have people in place to do that. So we work very closely. So the hospital admission risk program is the left hand of the right hand of remote patient monitoring in our organisation, because you do need somebody who is going to be able to robustly coordinate care. And certainly those that don't need a lot, remote patient monitoring can do that, but those that with a high degree of complexity, you do require an individual to do that and to work amongst the multidisciplinary team. And I've often said that if our systems communicated better, if we had better patient journey type platforms, then we probably would need half the staff that we have.
Thanks, Joe. I'll direct this final question to Peter. How will patient information be shared securely?
Look, these days, the modern technology can certainly cope with having a high level of encryption in transit for all of those sorts of things. And in terms of accessing at the other end, second factor authentication is pretty much universally accepted as a way to do that. It's still an obvious community concern, but to be honest, these days, it's from a technology point of view, it's actually much more straightforward.
We might leave it there, Tyler. Joe and Peter, thank you very much again. Our thanks to you and your colleagues for everything you're doing at the front line. Joe, we better let you get away and attend to to the critical stuff you've got to attend to, and good luck today with that, and thoughts are with you. Thanks to both of you again.
Pleasure. Thank you.